I'm very happy to introduce Dr. Palmer, Renee Bullock Palmer. She's well known to most of us. She's the director of non-invasive cardiac imaging and director of Women's Heart Center at Deborah Heart and Lung Center in New Jersey. She's an associate professor of Department of Medicine at Thomas Jefferson University Hospital. She is an imager. She does multimodality imaging, and she completed her medical school at in University of West Indies, and then did her residency and her cardiology fellowship at SUNY Downstate, and then did an advanced multimodality imaging fellowship at St. Luke's Roosevelt Hospital Center, which is an affiliate of Columbia University in New York. And she also is very active in women's heart disease, cardiac amyloidosis, and adult congenital heart disease. And she's going to teach us about adult congenital heart disease today and the imaging for that. Renee, please go ahead, take over.
Great. Let me just share my screen again. Okay, great. So thank you so much, Dr. Bakari. And I'd also like to thank Dr. Sengupta for inviting me to be here today to give this talk. So I'm going to dive right in, and we have a couple of real cool cases to show. So the goal for today is to outline the general principles for performing cardiac CT in adult congenital disease, including radiation dose strategies, and some of the best practices in performing this modality in this population, and reviewing the AUC criteria for CT in ACHE patients. And we'll also show some case examples to drive home the point. So of course, cardiac MRI is the preferred modality in this patient population, a lot of the times due to the lack of radiation exposure with MRI. But in some cases, there's limited access to cardiac MRI, and for different reasons, the patients may have various prostheses or devices that may not be incompatible with MRI. But not only that, but may also introduce artifacts. And with this patient population, especially because it's such a complex anatomy, you want to make sure that what you're looking at is real. So the lack of artifacts, is very important that we minimize artifacts. Claustrophobia is another reason why some patients may opt, or some providers may opt to do a CT as opposed to MRI. And when looking at certain aspects of the heart, such as vascular stents, coronary arteries, pulmonary artery stents, there are times when the CT just provides a better image because of the higher spatial resolution. So of course, when performing this study, you want to make sure that you're doing the right test for the right patient at the right time. It should be clinically indicated. You want to make sure that you're doing the test to answer a particular question, and that if there's any other modality that could answer the question without the risk of radiation, then of course that's the choice that you should go with. But after we've gone through all of that and the patient is there for the study, you want to make sure that the patient is centered appropriately in the gantry. You want to adjust the contrast injection and the image acquisition so that we can get as much information from the scan that we need. There are times, as we'll show in some of the venous structures, you may have to do a delayed scan to make sure that you're ruling out any thrombosis or stenosis. The delayed scan does not have to be necessarily gated if you're looking at a larger structure, such as the pulmonary arteries or the pulmonary veins. For the patients, especially for children, for small BMI, BSA, you can drop the KVP as low as 70 and even lower to 50 if it's a small child. I know for at Robert Wood Johnson, you guys may have a larger pediatric population than we do here. I myself, when we do these CTs, we do them for adult congenital patients. If it's a pediatric patient, those patients are sent to St. Christopher's or CHOP to have the studies done there, or of course to do an MRI. For larger adolescents or adults, then 90 to 100 kVp can be done if it's a thinner patient. Also, dependent on the system that you have, there's some dose algorithms that can actually decrease the tube current and adjust the KVP based on the patient's size and weight. That's the preferred way to go about this. If you're looking at a larger structure, such as a volumetric scan, you're looking at the ventricles, or looking at the larger structure, then you can increase the pitch of the scan to decrease the radiation exposure. If you're not necessarily looking for LV volumes and just looking at like pulmonary veins, looking for pulmonary vein anomalies, and a prospectively gated study can be done rather than a retrospectively gated study. And of course, you can consider this, especially if you're not looking at the coronaries as well. You want to minimize the acquisition window as small as possible, just to answer the question. So you might want to start just at the carina down to the diaphragm if you're focusing on the veins and the coronaries. You may extend up to the arch if you're looking at shunts like the Glenn shunts or different types of shunts that may be used in this patient population. So, for the study to be done adequately as well, you want to make sure that the patient understands what the study entails. You explain to them what's happening, and of course, they should be able to follow the instructions. In some of these patients that we image, they may have, challenges in terms of, mental challenges. It's very important sometimes that you may have to even have the patient, the relative, of course, be close by, not in the room, but of course, close by on the day of the scan to calm them down. Sometimes you may have to give anxiolytics as well. Usually the performing of the scan starts before the day of the study, because you want to gather as much information that you can on the patients, such as prior tests that were done, even if they were done at another institution, prior procedures, surgeries, and really knowing what you're looking for at the time that you're doing the study, and having an effective communication. It's it's a village that it takes to take care of these patients. And even as an imager, communicating with the referring provider, the technologist that's performing the scan, and sometimes even the surgeon that you might be referring the patient to. So looking at scan sequences, when we do these studies, like I said, you can do retrospective or prospective depending on what you're looking for. Usually with CT, with a retrospective gated study, as is shown at the top, if you're doing a full dose retrospective gated study, which we try not to do, but in those cases, you're imaging the scanners on through multiple cycles, right through systole and diastole, as is shown on the top. That gives you the highest radiation exposure. So you really want to make sure that you really need to do that before you expose a patient to that. Most oftentimes when we're doing retrospective, we're doing with dose modulation, where we drop the dose during the systolic phase and then ramp up the dose in the diastolic phase. Sometimes we may flip that depending on what we're looking at for congenital patients, and also dependent on what the patient's heart rate is, or even heart rhythm. Usually that leads to a 30% dose reduction with dose modulation. We can then lower it even further with prospectively gated studies, where if we're just looking at the coronaries, like let's say it's a patient that has had DTGA with an arterial switch, where you're looking at the buttons of the coronaries to make sure that there's no stenosis. If that's your sole purpose for doing the scan, and doing a good quality prospectively gated study can give you the information that you're looking for, and that will yield you a 70% dose reduction with prospectively gated study. Of course, there's a high-pitch helical gated study where it's a single beat study that can even get you to a lower dose reduction. So there are various options here, depending on what you're looking for in terms of radiation dose reduction, and being mindful of each of these is very important when selecting the protocol for your patients. Now, the contrast injection protocol is very important. So normally when you're just doing a plain common coronary CT look for the coronaries, usually the biphasic injection is what's used, because you're focusing on the left side of the heart to pacify the chambers and the coronaries. But usually with these congenital patients, because you also are interested in what's happening on the right side of the heart, you want to make sure that the right side is adequately pacified. And in this case, you're doing a triphasic injection protocol, where you inject contrast followed by a mixture of contrast and saline, and then then you end with a chase of saline. So it's a three-phase scan to really give you good opacification of both the right ventricle and the left ventricle as well. And as you'll see in some of these case examples, you really are able to get good quality images. In some cases, such as your single ventricular patients with Fontan circulation, you may have to do a 60-second delayed scan where, because sometimes they may have swirling and mixing, and it's really difficult to see, is that a thrombus? Is there obstruction of that Fontan conduit? You really want to do a 60-second delayed scan to see if that clears and if what you're thinking is real or not. So the patient preparation, as I mentioned, is key, and getting all of that information, the contrast acquisition timing, we spoke about the scan sequence and the scan range. So all of these four areas are very important when trying to do the best scan for the patient at the right time. So I'll refer you to these expert consensus statements from SCCT and from ECC. The earlier one in the background here was from the original document in 2015 that was published by SCCT by Dr. Kelly Han and colleagues. And it's really a nice article to go through, especially if you're thinking of doing this at your institution or even already doing it, but just want to see what's the best way to protocol your studies and improve the quality of your studies. More recently, there is a 2020 ACC appropriate use criteria for multimodality imaging in these congenital patients. And that's really looking at things from a 30,000-foot view in terms of managing these patients. And of course, choosing, what type of imaging, be it echo, TEE, CMR, or SCCT, or CCT in these patients. With regards to the clinical aspect of these patients and managing these patients, the 2018 ACCHA guidelines is really a go-to document for these patients. For our fellows here, we go through these sometimes when we're managing these patients in the clinic or on the floors, really knowing, okay, what are the complications that we should be looking for these patients, and what's the strategy in terms of, diagnosing these patients and even knowing when to intervene in terms of shunt closures, surgeries, and so on. Now, looking at the anatomy, so when we're seeing these patients, we're looking at, okay, what's the anatomy that this patient is coming to the lab with or coming to you in the clinic with, and then what's their physiologic function. So on the right in pink, that's a congenital anatomy, and this may range from something very simple as a PFO or very small secundum ASC asymptomatic or PDA to very complex patients where you're dealing with a single ventricle Fontan that might be failing, coming in with arrhythmias. So that's a much, much more complex patient. So we really have to understand the field in which you're playing with, and when you're seeing that patient. And then also the physiologic stage of that patient. What's the functional class? Is it someone that's living a normal life, playing sports, having no limitations, or as maybe in the case of the PDA, small patent arteritis arteriosus, or is it someone that really is almost wheelchair bound, can barely walk 10 feet with a functional class 4 with cyanosis and severe hypoxia? So it's very important that you're understanding this when this patient is referred to you as an imager, because what you may select for that patient may be customized depending on what that patient can tolerate. There's some patients that just cannot tolerate acquiring a study on their back. They have to do like a more echo and something that's more by the bedside. So taking all of those features into play is very important as well. Now, in terms of knowing which modality has different strengths, I think this table really lays it out very nicely. Of course, of all of the four modalities, echo is the more cost-effective strategy with less cost. It does not have any radiation exposure. You can get nice images of the volumes of the ventricles, particularly the left ventricle, dependent on the size of the patient. For pediatric patients, you may sometimes be able to see the corners, usually not so much so for the adult patients. And then same is true for extracardiac vascular anatomy. It can be very challenging with echo looking at that. And that's where CMR and cross-sectional imaging with CMR and CT has its strength, in that you can, particularly for both CMR and CT, you can look at extracardiac vascular anatomy. For CT, you can have a very good view of the coronaries and the course of those coronaries. Ventricular volumes of the four modalities, CMR has that greatest strength in looking at the size of the ventricles, the volumes, and so on, and even at the valve function as well. Both CT and CMR is costly, so there are some institutions that may not have all of these modalities, that they may have to refer outside to have this study done. And it's not just having the study or having the nice camera there and with all the technology, but then do you have someone that can interpret these studies? Because I can tell you, looking at these studies, it takes time, and sometimes you have to go back and look at that surgical report or looking at that prior study to really see if what you're seeing or what you think you're seeing is real or not. And of course, there's invasive testing with cardiac catheterizations. There are times where the patient may not be doing very well, and you really want to measure your QP-QS ratio. You want to look at other things, and may even have to make some decisions about treating these patients, especially if you can put a stent in a fontan that's thrombosed. There are times when you definitely need to send these patients for an invasive cardiac catheterization. And really communicating this with the cardiac catheterization interventionalist, and ideally, if someone is more like here at our institution, or ACHD interventionalist, he selectively, is a person that we go to in terms of doing these catheterization procedures, because they do take time, and you want to make sure that you're getting the information that you need from these patients, from the study. So this is actually just to show you, that you can get good information on the volumes of the ventricle, both the left ventricle and the right ventricle on CT, especially if it's a good quality study without any arrhythmias. And we use that sometimes quite a bit with our patients that we refer for CT. Now, looking at starting from the outside of the heart, the aorta, coarctation of the aorta, that's an area that we can look at with CT and also CMR. Usually with these patients, when you're initially seeing these patients, it's very important to get cross-sectional imaging and not just depending on that echo, because sometimes the echo can underestimate that gradient that we're seeing in the descending thoracic aorta, because you have of course, the shunts from the intramammary connections with the coarctation. So usually getting a good CT CMR is very important when you're seeing these patients initially. And if they're doing well, stage A, you have a good quality scan, seeing them at that initial visit, then you can look to repeat that study in probably 36 to 60 months if they're doing well. If they're not doing very well, like looking at a physiologic stage D patient, then you might want to do that more frequently, 12 to 24 months. And of course, if you're doing serial testing, then CMR is a test of choice if you have that option. Looked at anomalous pulmonary venous connections. Definitely, again here, cross-sectional imaging with CMR or CT is very helpful. With CT, you may not need to gate to have these studies done retrospectively. You could do them prospectively, and even do a non-gated single cycle, single heart beat study can get you the information that you need. And it has a class 1 level of recommendation when you're seeing these patients. So sometimes these patients come to us through the echo lab. You may be imaging a patient in the echo lab, looking at the study. The RV looks very enlarged. The RA looks very enlarged. You're not really seeing a direct interatrial or interventricular shunt. And what you might be missing is a sinus venosus ASD, which it's very, very difficult to see on transthoracic. Oftentimes these patients are sent for TEE, and even when you do the TEE, sometimes they may have to go to that cross-sectional imaging to look at anomalous pulmonary venous return, which can sometimes be missed on echo. And this is just an example of, this is a still frame of a patient that had a sinus venosus ASD repair, where you can see what's that, sequelae of that surgical repair that was done. And in this particular case, the patient had baffled this patient actually had anomalous pulmonary venous return involving the right upper and lower pulmonary veins, and both of these were baffled over to the left atrium surgically to correct the anomaly. Now, this is another case, and this is actually a video. This is a very interesting case that came to us. He was in his 60s, 62 years of age, and he gave us a history of having had an ASD repair in childhood. And then he's been having this very long-standing cyanosis. He actually came to see me in the clinic on home oxygen with pulmonary hypertension. He was seen in the pulmonary clinic, was thought to have pulmonary disease. He was a chronic smoker. And unfortunately, he had suffered a stroke, at another institution, and it came to us for a second opinion. So, the echo that was sent to us with the patient was that he had a PFO, and that was thought to be the source of his stroke. And, can he have this closed percutaneously? The echo that we did actually suggested otherwise, though, because it suggested that he likely had a sinus venosus ASD, and we actually had to do a TEE to reach a diagnosis of the suspected sinus venosus ASD, and he was referred to us for the cardiac CT to look for pulmonary venous return. So I'll walk you through this study. So this is actually looking at that pulmonary vein that's anomalous, and to the naked eye, you might think, okay, this is going over into the left atrium, right? But what's actually happening here is that just at that junction between the IVC, so this is an inferior sinus venosus ASD, you can see that the connection there, just as it's at the junction of the IVC with the right atrium, that vein comes into that area, and then there's actually shunting of that mixing of blood between the right and left side of the atrium, as we can see very see well here. And then in the other views, I can show you a little bit more carefully here. So you can see here that there, when you're looking here on the still frame, that there's mixing up of blood there, and you can see that there's something here. I'm just going to play again, right? You can see that there is some shunting from the left side into the right atrium, and then we can see that vein there. And then looking at the other video here, let's see very well. Right, so you see that's the sinus venosus ASD, and you can see that the vein comes in there just at the IVC. And I think, what you have to be very careful with these patients, because when you're doing a TEE, this patient actually had a right middle pulmonary vein. And I think, what may have happened at the other institution was that they may have seen four pulmonary veins and say, oh, there's no anomalous vein, not realizing that this vein that they're looking at. So this is the right upper, the right middle, and the anomalous right lower pulmonary vein is what you're seeing here. That is a still frame here. So you have to be very careful, that although you see four pulmonary veins, not necessarily that does not necessarily rule out anomalous pulmonary venous return, because they may have five pulmonary veins, right? As was in this case, that was anomalously returning over to the IVC through that sinus venosus ASD. So this is a good example of an inferior sinus venosus ASD involving the IVC, as opposed to the superior sinus venosus ASD that can sometimes involve the SVC, and in that case, oftentimes will involve the right upper pulmonary vein. So he went on, and the volumetric portion of the study had showed that his EF was slightly reduced. The right ventricular size was massive. The end-diastolic volume was 360. The end-systolic volume was 200. He went on to have a cardiac catheterization that showed a mildly elevated transpulmonary gradient with pulmonary vascular resistance, biventricular shunting, and the angiogram had revealed that anomalous right lower pulmonary vein entered just at that IVC-RA junction, and with a bidirectional shunting. So we actually had referred him to an institution in New York, where he had been seen by an ACHD CT surgeon and had closure of that sinus venosus ASD and baffling of that vein over to the left atrium. And I saw him like a few months after the surgery. He was doing remarkably better. He was off his home oxygen and was doing much better with functional incapacity that had improved with sent him for cardiac rehab. So, sometimes even in middle age, this is someone in their 60s that could have just been trucking along as having pulmonary hypertension due to lung disease, not realizing that what he really has is an underlying congenital condition that was not properly corrected in childhood, that had just lingered over time and worsened his condition. So moving on to tetralogy of Fallot. So this is the largest population of patients that we will see as adult cardiologists in our clinic. And it's very important that we understand what are the complications that can happen over time in this patient population. The most important and the most common complication is pulmonary vascular regurgitation, right? Because remember with the tetralogy of Fallot, you have that out the pulmonary artery is actually quite stenosed. There's right ventricular hypertrophy, and they have that VSD. So, usually the VSD is closed and the overriding aorta. That's the tetralogy. The overriding aorta, the VSD, the right ventricular hypertrophy is secondary to the RVOT obstruction. So usually in childhood, the VSD is repaired, and of course they have opening of that stenosis in the RVOT. And over time in adulthood, this leaves them with pulmonary valve regurgitation over time that can enlarge in the RV, can lead to RV heart, right ventricular failure, can even lead to arrhythmias if that right ventricle gets very enlarged, and sometimes they have to put an ICD there. Sometimes what happens is that they can develop branch pulmonary artery stenosis in the branches of the pulmonary arteries. They may develop restenosis of that RVOT. So there are lots of complications that these patients can have, and even they can develop dilation of that aortic root because they have that large overriding aorta. So those are some of the complications that these patients can have. And CT, CMR play very vital roles in looking at these patients. Oftentimes, if they're doing well, you get the CT and then you can repeat it in 2 to 3 years. Same for a CMR. If they're not doing very well, they have to be watched more closely. You're doing these images, particularly if you have to do them at least yearly or every 2 years, I would opt more for CMR to decrease their radiation exposure. But what you're looking for is looking to see if and when that right ventricle becomes very enlarged, secondary to that pulmonary valve regurgitation, because what you don't want to do is to wait too long and then they go into a right ventricular failure due to RV dysfunction. This is actually a case that we had here a couple of years ago. Let's see if everything plays first. Okay, right. So she actually came to us after having tetralogy of Fallot repair. She developed severe pulmonary valve insufficiency, and which was a common, as I mentioned, common complication of these patients. And she was actually referred to us for consideration for percutaneous pulmonary valve replacement. So, CT plays a very important role in actually pre-procedural planning for these patients for the different types of valves that they have. We have the Altera valve, the Harmony valve, where we can, fortunately, we can actually replace these valves without having to do a reduced sternotomy. And so we do quite a few of these CT studies here to look at the dimensions of that RVOT, the length of that RVOT, the relationship to the coronary is very important, and also the relationship to the sternum. So these are some of the things that we look for in these cases. And in this patient, you can see the RVOT is very, very large. The right ventricle is dilated, and there is pulmonary valve insufficiency as well. The right ventricle, although the function is relatively preserved, you can see that there's that apical ballooning there, so it's not quite normal. The LV is slipper shaped because you have that very flattened septal wall bulging from right to left, indicating that that patient has significant volume overload of the right ventricle. It's another case of a patient that had, so this patient actually, in this particular case, went through having the pulmonary valve insufficiency and then had pulmonic valve replacement. And this patient was sent to us just to see how they were doing in terms of the valve, if it's functioning well, and also relationship to other structures. And you can see here that we can see very, very clear images of the pulmonary valve. It was opening very well. Didn't really see any stenosis. You can get 3D measurements across, the 3D volume rendered images to see the relationship of the pulmonary artery. So very useful in this particular case. So for this patient, the valve was functioning well, and she, went on her way to follow up with her referring provider. Another case of a patient here, so this is actually a still frame of a patient that actually had supravalvular pulmonic stenosis. You can see here, this is the RVOT, the pulmonic valve, and you can see a very tight stenosis here above the ventricle, and and you can see that here in the cross-sectional view that is very kinked. And in this particular case, this patient was referred for surgery to have that fixed as well. This is another case, different in this particular patient. So this patient actually had a valved conduit, and sometimes what they'll do is replace the RVOT with a conduit, and within that conduit there's a valve. This patient actually had that conduit done, and in this is again a still frame. You can see that the valve here, there is some low Hounsfield unit here within the valve, and actually this patient had severe stenosis of this conduit. The mean gradient was 50, and looking at it here, you can see that this area here is quite small, and this patient went on to have surgery to have this replaced as well. The other condition that we can see that's helpful with CT is the double outlet right ventricle, DORV. So these patients it occurs when the aorta connects to the right ventricle instead of the left ventricle, and both the pulmonary artery and the aorta rises from the right ventricle. So in this particular case of VSD, there's an obligatory VSD because, of course, these patients cannot survive without intracardiac shunting. And there are four main types of DORV that you can see. There's a tetralogy flow type, where you have that subaortic VSD and pulmonary stenosis. There's a TGA, transposition of the great artery type, where you have the DORV with subpulmonary VSD, but no pulmonic stenosis. And you have the VSD type variant, and then you have the univentricular heart variant, where you may have mitral atresia, an unbalanced AV septal defect, and then you have one ventricle, be it the left or the right ventricle, that might be hypoplastic, and these patients often have to be treated and repaired with a Fontan repair. Now, focusing on the tetralogy of Fallot type DORV, these patients tend to present almost like tetralogy of Fallot patients, where they may have pulmonary valve insufficiency. They will oftentimes, by the time they can come to us as adults, their VSD is repaired. They can also have branch pulmonary artery stenosis. So oftentimes these patients are presenting similar to the tetralogy cases that I showed earlier. Rastelli procedure is another option that these patients can be treated with, where the conduit is replaced. And I'll just go back here. The VSD is closed, and then the conduit is created from the right ventricle to the pulmonary artery, and the aorta is then shifted back over to the left ventricle to correct the condition. This is actually a case of a patient that had a double outlet right ventricle. And you can see as we're coming down from on the axial views from the cranial position. And you can see here that the pulmonary artery is coming in, that RVOT is dilated. And you can see here there's that overriding aorta. And the right ventricle is quite enlarged. And the patient has a device. The right ventricle was about 20%. The EF was 20%, and the patient had an ICD that was placed. Let's see if I can speed this up here. Right. And that's just showing the massive right ventricle, and this patient actually had pulmonary valve insufficiency. As we can see here, this is another view of the heart. And so you can really get good images of the ventricles in these cases. Let's just go back here. Thanks. Okay. Right. So just looking at the measurements, so looking at the size of the pulmonary artery and the relationship to the coronaries are very important. We also look at the angle of the pulmonary arteries, and also looking for any branch pulmonary artery stenosis as well. The length of the pulmonary artery, both in systole and diastole, is also very important as well. And the coronary, the relationship of the pulmonary artery to the coronaries, and also the level of which the coronary is closest to the pulmonary artery is very important, because sometimes these cases, when they go in with the percutaneous valve, there is a risk of actually, compressing the coronary, and they can go into VTAC in the cath lab if this is not realized and not prepared for. So sometimes you have to even put a wire down into that left main to make sure that if they get into trouble, they can easily deploy a stent, and of course to make sure that the size of the valve is adequate, but not to the level that will end up compressing the coronary. So these are some of the important things to consider when we're looking at these patients. So, there's actually a very good paper by a CCT and JSCCT that goes through looking at what to look for in these patients. And as I had mentioned, the pulmonary valve insufficiency, the stenosis of the conduit, and branch pulmonary artery stenosis. The reason this is also important is that there's a registry called the Indicator Registry that looked at, these cohort of tetralogy flow patients. And it was very important that a comprehensive pre-operative evaluation before the pulmonary valve replacement showed that the older the patients are at the time of presentation, and also the presence of right ventricular hypertrophy and RV dysfunction were predictive of a shorter time to post-operative death and sustained ventricular tachycardia. So like I had mentioned, you want to make sure that we capture these patients before they go into heart failure, and also as soon as we can, and not wait for them to be, beyond the ability to recover that right ventricle. And remembering that when we're checking these measurements, so we measure these measurements both in systole and diastole, usually at the 30% phase of the cardiac cycle, and at the 70% phase, you're looking at the eccentricity of that RVOT, as well as the perimeter of the RVOT, both in systole and diastole. Realizing that the RVOT is dynamic, it expands in systole and contracts in diastole. So really making those measurements of both of those phases is important. Looking at the level that we measure these, usually the distal RVOT, the annulus, the main pulmonary artery, and also the pulmonary artery bifurcation. You want to look at the length of that landing zone, because that will determine what type of valve is able to be placed in that pulmonary artery when you're planning for these patients. And this is just what it looks like. You can see that there can be quite a lot of variability in systole and diastole. In this particular case, that length from the annulus to the bifurcation is 1.8 in systole. It expands to 4 centimeters in diastole. And that's why when we report these cases, we report both in systole and diastole, so that the vendor can understand, how long that valve would need to be, and the dynamic nature of that particular patient's RVOT. Looking at the various variations of the branch pulmonary artery anatomy is important. For some cases, as in this case, it can almost be, this one is, in this particular case, the left pulmonary artery is almost diminutive, and also the angle at which it comes off, sometimes it has an acute angle. These are some of the things that will need to be assessed before putting in the valve. And 3D printing can also be very valuable in understanding the anatomy that the surgeon has to deal with before going to the emergency room. The operating room, sorry. There are different types of RVOT, the class 1 through to class 5. These are the various examples of them as well when you were describing them in the report. So the coronary, this is an example of a coronary that would be at risk with compression. You can see that's the large aorta, the pulmonary artery, and you can see that this coronary in this particular case could be compromised during the procedure, and it's very important for that to be realized. When the coronary comes above the sinatubular junction, is also another example of a high-risk coronary, and you want to plan for that before going into the procedure as well. And then looking at the relationship of the RVOT and the aorta with the sternum, because oftentimes these patients, if they're going to go to the OR again for reduced sternotomy, that you want to know how deep that pulmonary artery is. Is it just beneath the sternum, and planning for that as well, in addition to the coronary. Sometimes the coronaries may pass in front of the pulmonary artery. very important to know this before going into the operating room. These are the different types of valves that are available, and the sizes. So just being very mindful of that when we're reporting these studies. And this is just an example of the important reporting elements when we're looking at these patients. And like I said, this was published last year, or the year before, the Journal of SCCT, if anyone wants to refer to that. So moving on to the Resteli repair, this is what I had mentioned before with these patients with the double outlet RV, that you can actually replace the RVOT conduit with a conduit as is shown here, close the VSD, and this is an example of a Resteli repair. Now, moving on to the DTGA, in these patients with the transition of the great arteries. In these particular cases, they have to have repair surgically, otherwise they cannot survive infancy. And in this case, you have the aorta rising from the right ventricle, the pulmonary artery rising from the left ventricle, and the circulation is in parallel rather than in series. So oftentimes these patients will have to have surgery. In the older days, we did these patients through the atrial switch with the must ascending repair, where we would baffle the flow from the IVC and SVC over to the RV and then out to the pulmonary arteries, and we'd baffle the veins over to the left ventricle and out through the aorta. There's lots of complications that can happen with these repair patients with the atrial switch. They can have arrhythmias, they can have stenosis of the baffles, they can have baffle leaks as well. Because the right ventricle is functioning as a systemic ventricle, over time the right ventricle can become, RV failure through systolic dysfunction. Now, younger patients, usually since the 1980s, we have realizing the complications with the atrial switch. A lot of these patients, especially in their 20s and 30s, will have arterial switch, where what's done is that you have transposition of the surgical transposition of the great arteries, where the aorta is corrected and placed over to the left ventricle, and the pulmonary artery is placed over to the right ventricle. It's something called the Lecomte maneuver, where the pulmonary arteries are stretched across the aorta. Sometimes these patients can develop stenoses here, and the coronary is very important. The coronary buttons have to be reimplanted, so these patients can actually have coronary osteostenoses that you have to be very mindful of when we're looking on cardiac CT for these patients. And usually CT again is very useful in this patient population, depending on how sick they are, more frequent imaging as opposed to less frequent imaging. And this is an example of a DTGA that we had in our lab, a patient that had, she saw me in my clinic actually, with systolic dysfunction of the systemic right ventricle. And you can see here that she had the atrial switch, where that RV is massive, it's hypertrophied because it's a systemic ventricle. And the veins, the pulmonary veins are baffled over to the left atrium and then through into the right ventricle and out through the aorta. And the veins, the IVC, the SVC, from the head and from the lower body is then shunted through the over to the left ventricle and out through the pulmonary artery, because the left ventricle is a subpulmonic ventricle in these cases. And this is just a still frame showing how massive that RV can become and very hypertrophied as well. And you can see that the pulmonary artery and the aorta are actually in parallel rather than perpendicular, as is often seen in the normal anatomy. In this patient, she actually had a SVC stenosis. So she had a lead that was placed years ago. She had developed AV block and had required pacemaker placement. And over time, what happened is that she developed a lot of fibrosis around that lead and had stenosis of that SVC. And you can see a close-up of that. There's actually no flow in that superior, in that SVC, and she actually had to have stent and removal of that device from the SVC. And this is just an example of that here, where you can see there's really hardly any flow in that SVC. The IVC was patent, as is shown here. And this is the same patient. And you can see that the veins here are patent, the pulmonary vein, and the baffle across from the pulmonary veins over to the systemic, to the left ventricle and out through the pulmonary artery. The arterial switch, so didn't have any examples of a patient with arterial switch, but this is actually what it looks like on this case in MRI, where you have the aorta and then the pulmonary arteries are almost like draped over the aorta. And what can happen, as I had mentioned, is that these you can have branch pulmonary artery stenosis in these cases. You can also have the neo-aortic root, it becomes very dilated, and they can also have osteostenosis of the coronaries. And again, CT is very valuable. So the last real pathology I'm going to show here is Fontan, which is a very complex situation with these patients. So in this case that I'm showing here, this patient has a left heart hypoplastic syndrome, which is where you see a very diminutive ventricle, diminutive aorta, that's usually repaired with a Norwood stage procedure, which ultimately results in a single ventricular physiology, as is shown here. So just walking through this, these patients over time, once they're, have moved from infancy, they initially have to have the shunt, but then they have to have reconstruction of that aorta. As can you see how diminutive that aorta is here? With the Norwood stage procedure, there's there's reconstruction of that aorta, and then because the ventricle on the left side is so hypoplastic, it's really non-functioning. So that right ventricle becomes surgically borrowed to become the systemic ventricle. And what will happen is that the IVC, the SVC, then leads to a third stage of the surgery, where the SVC and IVC enter into that extracardiac fontan, which then dumps that flow into the pulmonary arteries and through the lungs to become oxygenated. And then here you can see that from that reconstructed aorta, that our RV is now functioning as a systemic ventricle. The LV is diminutive, not functioning, and this is the final stage of the Fontan procedure. So very complex situation. They have a lot of pathology that can happen, complications, both extracardiac and cardiac complications that they can have. They can develop, systemic venous occlusions. They can become usually these patients are walking around with a O2 sat in the high 80s, 88, 86, sometimes as low as 83%, because there's mixing of blood. They can become very cyanotic if that fontan here becomes thrombosed. They can become very cyanotic. They can have hemodynamic collapse because there's actually no blood going there. If they have a pulmonary embolism, that can be fatal for these patients as well. So this is actually a case that we had in our lab, and this patient came to us through our pediatric cardiology colleagues. There was resting cyanosis, was very short of breath, and he was referred for a cardiac CT. And you can see that there's a Fontan conduit where you have the IVC, the SVC, enters into that conduit, and then it then flows into the pulmonary artery. And this is what we call the superior limb of the fontan, the inferior limb of the fontan. Sometimes what can happen, because there's no functioning pumping ventricle in this system, they can have very prone to have thrombus here, and sometimes these patients have to be on anticoagulation if they've had that history. In these cases, you have to have a 60-second delay, because if you don't do a delayed scan, you can end up overdiagnosing or misdiagnosing a patient as having thrombosis when there is none. So we always do a delayed scan on these patients. And this is just showing here where that interatrial septum, there's actually atrial septostomy. You have this huge atrial chamber shared with the left atrium, the right atrium. You're seeing it posteriorly here. That fontan conduit here is non-fenestrated, meaning that there's no communication between the fontan conduit and the right atrium. Sometimes if they have a lot of congestion, you may have to have a pop-off valve, where you may have to create a fenestrated fontan. So those are some of the variations that we can see here. The systemic ventricle, which is the right ventricle in this case, is very dilated, it's hypertrophied as well, because it's then pumping that blood into that aorta, which was reconstructed for this patient. This is looking at it on the cross-sectional, on the axial views, and you can see that very large biatrial enlargement, as you can see here, wide open interatrial septum. And this is actually the patient's diminutive aorta, right? Where you're seeing that the corner is coming off, and this is a reconstructed aorta that the patient had as well. I'll just have that play a second while you guys take a look at that. And in this patient, the patient also had coarctation of the aorta, as is shown here, and this patient actually had to have that repaired. And this is all the same pathology in this one patient. And more importantly, what was causing the cyanosis for this patient was actually admixing of right to left blood, where you're seeing a conglomerate of venous collaterals from the right side, and there's actually communication with the pulmonary vein with flow causing cyanosis. So these actually had to be coiled. You know, we most oftentimes can't coil all of them feasibly in one setting, but we coil as many as we can. And this patient actually had improvement in his hypoxia. This is actually a patient that came to me, another Fontan patient. And this time she came because of syncope, such as having episodes where she was passing out, exercise induced, and she was referred for a cardiac CT. Just for simplicity, these were still frames. And on the delayed scan, she had this entire conduit that was thrombosed. And this was actually the delayed scan, and it persisted. And her right ventricle, ventricular function was actually, the LV was 44% EF, and the RV was 55%. Her initial reason for the Fontan was due to tricuspid valve atresia, so the left ventricle actually had to be functioning as the single ventricular ventricle, and the Fontan had to be created due to the fact that the RV was hypoplastic from the tricuspid valve atresia. And this is just the angiogram that showed that she had that conduit, the Fontan that was thrombosed, and then she had to have it stented. And this is a post-stent angiogram, which showed improvement and no further episodes of syncope. So the last few slides, this is it for the cases, but just going through why I believe it's very important if you're doing CT imaging, you know, you're gonna come across these patients. They're gonna wander into your into your CT lab, and you know, it takes time to grow this practice. And I think this paper was actually published last year in JCCT that looked at the rapid growth of CT utilization compared to MRI and echo. And as you can see here, this was over a 10-year period of 2014 to 2024. 15 US centers were studied. And what they saw is that there was significant increase in the use of CT compared even with CMR and echo, and multiple reasons for this. You know, and this is why I think it's very important that you know, when we have these patients, that we really take the time and to study them, and to also, sometimes there are cases where you may just have to refer these patients to a more a higher level of care that can read these patients. But you know, I think if you have an opportunity, especially for those in training, to really learn this area, it's going to be very important and be very invaluable. There's definitely a need for larger workforce in terms of reading these studies. This is what that study had also shown as well. And I think SCCT, the advocacy committee, has done a lot of work in terms of getting reimbursed for reading these studies, because it takes at least, I would say, 3 times the time it usually takes to read a simple coronary CT angiogram. And this is a paper that was published this year in JCT that looked at proposed resources required for starting a program in CT congenital imaging that I'll refer you to if you're interested. That goes through very nicely how to start such a program at your facility. And this was an abstract that we presented at last year's SCCT meeting, where we, within our population here at the board, we actually looked at or CT or congenital CT cases that we were doing, and a lot of time, a lot of these patients are actually you know, underinsured, unfortunately, and we have a healthy mix of various ethnicities that presented to us. Hispanic 13%. A lot of these patients were on Medicaid or charity care, higher than the state average. About a little bit more males than females. And we can see a lot of these cases came to us primarily for tetralgia, flu 40%, Fontan about 8%, TGA, and for other causes. And CT was very useful. We were able to send these patients for some form of intervention, be it surgery or percutaneous. Fewer lost to follow-up, and others, you know, did fairly well with continuous surveillance with no major adverse events. So just to finish up, you know, I think, you know, access, you know, how do we, you know, expand access? So, you know, imaging these patients take time, take expertise, and there's a great need to increase and increase the workforce to take care of these patients. Access, you know, be it access to great institutions to do these cases and to see these patients. Access issues due to underinsurance is also a big factor that comes into play. Usually when we see these patients here, sometimes we have to refer them to Columbia, we sometimes have to refer them to UPenn, and it takes a lot of paperwork, but I think with coordination, it can be done. Multidisciplinary care between the pediatric cardiologist, the CT surgeon, OBGYN, the hepatologist as well, and it really takes a village to take care of these patients. So comprehensive pre-procedural planning is important when looking at these cases, obtaining outside reports, outside studies, making sure that you're doing the appropriate test for the right patient at the right time. Looking at, you know, looking at interventions, both pre and post intervention, CT can be very useful. And there's a lot of work that's needed to improve access to care. And with that, I will stop here and I'll stop sharing my screen to open the discussion.
Thank you very much, Renee. It was a very comprehensive, excellent cases. So I'll just open it up. I think Dr. Himrani, I don't know if she's online or not. Yasmin, are you
Yes,
online?
yes,
Okay,
Dr.
good,
Pari, I've joined. Yeah.
good. So I think we'll have time for probably a couple of questions. So if Yasmin, you want to go ahead, start.
Yeah, and great presentation, Dr. Palmer, and appreciate you sharing your experience and your interesting cases of adult congenital heart disease. You know, I just had some thoughts about, you know, using CT and congenital heart disease. As you know, we use both, you know, CT, MRI, depending on the patient's prior history. A lot of times I have seen that we end up doing both. Now, we don't see that many here. I bet you see more than us. But and more so with MRI, sometimes you miss stuff because the spatial resolution is not as good as CT. So a lot of times what happens is we do CT and then you know the decision is, and I want to take your input on that, you know, when you are doing QPQS calculation, and although we, even if we do retrospective gating on CT, not as accurate as what we get in MRI. So was wondering what your thoughts are in this regard.
So absolutely. So I think they're complementary to each other, right? So the physiology you can't beat you know, with MRI. I mean, MRI gives you the volumes, you can get the QPQS ratio. But like you had mentioned, there's some cases where the spatial resolution may not be the best and they may miss things. So there are times that you may have to do both of those studies because you really can't take the risk of missing a diagnosis or misdiagnosing a patient. So you know, it's not ideal, but you sometimes have to do that. I do agree. So there are cases in which, you know, for the QPQS, if there's a reason that the CT, let's say the CT directs me that, okay, this patient needs a catheterization, then we can get that information from the QPQS. But like you said, if the patient is doing fairly well, the CT is not really showing any major pathology, and you really want to get what's the QPQS for that ASD, then I would get an MRI for that patient because you may not necessarily need to do an invasive study at that time if the QPQS is not significant.
Yeah. And another thing was about 3D printing. So we have been excited about 3D printing for quite some time now, but I still don't see it being used that often.
Yeah.
So
So
what?
I admittedly, I'm not an expert in 3D printing, but I know the guys at Columbia. I don't know if Dr. Bakari can speak of that because I know he was previously there, but they're very big on 3D printing. And man, I forgot her name now, but she speaks a lot at SCCT. If you have a 3D printer and you're able to do the printing, sometimes they may even have to refer these patients for a second opinion where they could probably provide those images for you. But it's very useful, and you know, having that model, that 3D model that the surgeon can look at before going to the operating surgery is priceless.
Yeah, we do virtual valve implantation, etc. So, virtually you can do a lot on a 3D printed model.
Right.
Of course, it won't have that elasticity, but if you have systolic and diastolic images, you can potentially, kind of use it to plan your procedure. Now, in pulmonic valve imaging, do you, so I'm sure it takes a lot of time to do all those measurements. Do you have Tremency or other, I don't think they have a pulmonary package, they just have tricuspid package. So how do you handle that? The
The
measurement?
measurements. So usually with the CT images, so as I can probably show you the image I had gone through with that. Yeah, that paper I had right. Right. So usually with the measurements here that I'm showing here of the different levels, so I'll actually report these both in systole and diastole, and I give the minimum and maximum dimensions. And I usually use a template that helps in putting that together in the report, because I think usually once we read them here and report them, it's sent to the vendor, and they will also look at the images and, and make a decision on the type of valve, and if the patient is an appropriate candidate for that valve. Does that answer your question?
Yeah, definitely. But again, so I feel like, if we do all the measurements manually, it really definitely takes, although you have
It takes
templates.
time. Yeah, it definitely takes time. And to be honest, sometimes it may take me at least 2 hours to read these cases and report them because, you really want to get the measurements correctly, and it just, there's no way to get around it. It just takes time.
Yeah, definitely. I'm seeing a message on the chat here. Thanks, great talk. Do you have a reference of dedicated CD protocols, including delayed imaging for specific congenital heart defects?
Sure, I'd be happy to share with you the protocols that we have used. I adapted them, I adopted and adapted them from the SCCT 2015 paper. So I can refer you to that, and I can also share the reference. I'll email these to Andrea this evening to share with the group some of the references I got, like the paper, on the pulmonary valve imaging.
Thank you so much, Dr. Palmer.
No problem.
If anybody has any other questions, please feel free to jump in, and you can either unmute yourself and ask or put it in the chat.
Dr. East put a question in the chat. Are there any studies looking into the lifetime radiation risk in congenital patients since our congenital folks are living longer?
Yes. So, very interesting that you had asked that question. There was a paper that came out, I think, last week, that looked at not just congenital patients, but all comers for CT, and naturally had mentioned that, the risk of cancer with CT exposure is increased, by at least 5%. So there's always that concern, which is why, when you're doing a CT or any radiation exposure test, you really want to make sure, do you really have to do this for this patient at this time? And is there another modality that can answer that question? And there are times in which we may, refer this patient for the MRI, and then based on the MRI, we might be able to get the measurements. And like he had mentioned, Yasmin, if the MRI cannot give you that spatial resolution, then you may then have to do the CT, but probably starting with the MRI first, and then, seeing if that CT is necessary, because there is a risk, and these patients are living longer, in their fifth and sixth decades. So over time, there's a lifetime accumulation of risk, which you'd like to minimize.
Yeah, and the same token, when we discussed the radiation reduction strategies and doing either prospective, or sometimes we have to do retrospective gating or do prospective with white padding. And we try to use that dose modulation. And in some cases, depending on the body habitus, you want to lower the kV, but even if you do a full kV, but you do dose modulation, this milliampere reduction, the image quality it deteriorates significantly. And then when you have to go look at face-to-face variability, it gets difficult to interpret.
Right. So it's a balance between the radiation exposure risk and getting a diagnostic scan to answer the question that you need to ask, that you need to have answered, right? Because at the same time, these patients are very sick, so you really do not want to miss the opportunity to diagnose them correctly, so it's not ideal. In an ideal world, we would not have to do a CT, or we could have radiation negative CT, which doesn't exist. But it's one of the challenges with these patients, and I think the story is still yet to be told, because these patients are surviving longer, and I think with time, we'll see what the practice patterns are like. And I found it very interesting that, because the paper I showed with the increase of CT use, I actually came across it over the weekend, and I found it very interesting, because I thought that, MRI would actually have a greater uptake, but I was surprised to see that uptake of CT. And I think some of it has to do with comfort levels in terms of interpreting these studies. Because like you said, with MRI, if you don't get the correct stack, if you don't plan the study properly, CT needs protocoling as well, but MRI more so, you can end up missing the diagnosis, so I wonder, and this is just anecdotally, I'm wondering if some of this is due to patients' comfort level not patients, providers' comfort level in terms of interpreting CT over MRI.
And I bet that exists. I remember when I was in the previous institute I was at, we had a dedicated congenital heart disease imager who would literally sit in the MRI suite all day long, protocoling every single study with the technologist so that they get what they wanted.
Right.
And in a busy cardiology clinical practice, and if you don't have that dedicated time to sit there, it's very hard to get what you want in all patients.
Right. And then that's the thing, you have to plan the stacks that you tell for MRI, the various stacks, like if you're going to do the stacks, the RVOT, if you didn't plan for that, then the information is just not there, and you sometimes will have to repeat the image and repeat the study again.
Have you used 4D flow and MRI on these congenital patients? What's your experience?
So my experience with MRI is not much, because we haven't had the 4D flow use here with MRI, but I don't know if there's anyone else in the group that has used it, but I've seen the images and they're quite impressive, for high quality.
Yeah, usually they're very big files. And sometimes in order just to open, I remember the data set, it takes a long time, takes a lot of space, where to store it, eventually goes to the PACS, but it's just a very slow process. And it takes longer to acquire it as well.
Right. I do see AJ on the call, not to call him out, but hi, hello AJ. I know he's a multimodality imager, so I'd be curious to see what he thinks.
Dr. Shah, what are your thoughts?
Yeah, no, I haven't even used much. Obviously, just seen the images in the conferences, but yeah, look forward to that. But it was a great talk. Thanks, Renee.
Thanks, AJ.
Always good to catch up. Yeah.
Yes. Yeah, AJ and I trained together in New York, so.
That's good to hear that. Yeah, so if there aren't any more questions, Dr. Palmer, we won't keep you here unnecessarily. It was an amazing talk. Thank you for sharing your experience and your knowledge. And hopefully we look forward to more talks from you down the road.
No problem. And